Good morning, everyone. Our lecture today about stress fractures. بس ثواني يا أستاذ. Okay, good morning, everyone. Our lecture today about a stress fracture. Stress fracture or fatigue fractures occur when normal bone is exposed to abnormal stress. So it is an overuse injury. They are seen in professional athletes and in military personnel. While insufficiency fractures are fractures which occur in abnormal bone when exposed to normal stress. They most commonly occur secondary to untreated osteoporosis in women and older people. طبعا قسم يعتبرون السترس فراكتشر هو فاتيج فراكتشر يختلف عن الانسفشنسي فراكتشر، وقسم اخر يعتبرون السترس فراكتشر ينقسم قسمين اللي هو الفاتيج فراكتشر يختلف عن الانسفشن، والقسم الثاني هو الانسفشنسي فراكتشر. فانا ان شاء الله راح احاول بهذه المحاضره اغطيهم اثنينهم. Epidemiology. The part of skeleton at risk of stress fracture clearly depends on activity undertaken. The vast majority of stress fracture occur in the weight-bearing bones of the lower limb, 95%, especially the lower leg and the foot. The tibia is the most common site, 50%, followed by metatarsal, 25%, and tarsal bone and femur, 8%. Stress fracture can occur in the upper limb in throwing athletes and rowers, but rare. Location. It is divided into high-risk site and low-risk site. High-risk site of stress fracture are location at greatest risk of progression to complete fracture, displacement, or non-union. These sites are under tensile stresses and have a poor vascularity. The high-risk sites include superolateral femoral neck, anterior tibial cortex, fifth metatarsal base, the grade 2 sesamoid, hallux sesamoid, talar neck, posterior cortex of the tarsal navicular, second to fourth metatarsal neck, marsh fracture, medial malleus, femoral head, patella, and parts interarticulars of the lumbar spine. While low risk sites of stress fracture are at low risk of complication and under compressive stress. The low risk sites include calcaneum, pubic rami, sacrum, ribs, proximal humerus or humeral shaft, posterior medial tibial shaft. Physiology. Bone is a dynamic tissue constantly remodeling under the influence of multiple hormonal and mechanical factors. There is a balance between bone resorption carried out by osteoclasts and bone synthesis carried out by osteoblasts. Bone has a remodeling response to mechanical stress, so that the greatest amount of bone is laid down in areas of greatest applied stress. When bone is subject to repetitive daily subthreshold loading, microcracks may occur within cement line. The normal remodeling process repairs these cracks. However, if the bone continues to be subjected to high stresses, then crack propagation. When the bone is subject to repetitive daily subthreshold loading, microcracks may occur within cement lines. The normal remodeling process repairs these cracks. However, if the bone continues to be subjected to high stresses, then crack propagation occurs. If crack propagation outstrips repair, then over a period of time, a painful established stress fracture will develop. It has been shown that during this process, osteoblastic activity lags behind resorptive osteoclastic activity. Risk factor is either extrinsic or intrinsic. Extrinsic factors pertain to the environment in which the athletes train, and intrinsic factor pertain to the athletes himself. Extrinsic risk factor include training regime like long distance running or training surface like running shoes, while intrinsic risk factor include bone anatomy like narrower bones, sex, include female athletes trait, include disordered eating, amenorrhea, and osteoporosis, nutrition like calcium and vitamin D deficiency, smoking, and drug like non-steroidal anti-inflammatory drug. Clinical presentation. Stress fractures normally present with worsening pain with a history of minimal or no trauma. In the lower weight-bearing limbs, there is often a history of recent increase of physical activity or significant alteration in the type or duration of normal athletic activity. Radiographic features. Plain radiographs have a poor sensitivity about 15 to 35% in early stage injuries, which increases in late stage injuries 30 to 70% due to possible callus formation. MRI is the most sensitive modality for diagnosis of stress fracture, and it is an important tool to distinguish high and low risk fractures to help clinicians for management plans, and sensitivity reported to reach close to 100%. A plain radiograph has a poor sensitivity in detecting stress fractures, as positive findings may take months to appear. During the first few weeks after the onset of symptom, X-rays of the affected area may look normal. This is the example of initial AB X-ray of the foot of the left foot in patients with stress fracture of the second metatarsal bone, which appear normal. While this X-ray follow-up after 2 weeks appear a periosteal reaction. Positive finding on X-ray can include either a gray cortex sign, which is a subtle loss of cortical density in early stage stress injury, or it may show increased sclerosis or cortical thickening along the fracture site, or periosteal reaction. Elevation may take up to 2 weeks to be detectable and may show fracture lines. This is X-ray, show a gray cortex sign. Lateral X-ray of left tibia show consecutive lucency in the anterior cortex of the mid shaft. This is a gray cortex sign. Also, another picture of gray cortex sign show a lucency in the anterior cortex of the right tibia with pretibial soft tissue edema. This is a radiograph of early stress fracture. Oblique view of the foot show a periostitis of the medial cortex of the third metatarsal bone with a subtle lucency, representing the start of a break in the cortex. تلاحظ هنا اكو periostitis with lucency. While a follow-up X-ray after 3 weeks show complete cortical fracture with oblique lucency. This is after 3 weeks. Another example of stress fracture show ill-defined linear area of sclerosis at distal tibial metaphysis. This is the sclerosis representing stress fracture. A chronic radiographic finding of stress fracture, this is the X-ray of the tibia, show a mature periosteal reaction. This is a periosteal reaction with lucency and endosteal reactive changes. Stress fracture of the fifth metatarsal bone has been fixed previously with screw. This is the old fracture has healed, and now there is a fracture through lateral cortex of midshaft of fourth metatarsal bone with a periosteal bone formation consistent with a new stress fracture. فهاي البيكتشر بيها old fracture اللي هو healed و new stress fracture. Nuclear medicine. Bone scans can show evidence of stress fracture within a few days upon the onset of symptoms. As a modality, it is considered less sensitive than MRI. Stress fracture on bone scintigraph appear as a foci of increased radioisotope activity hotspot due to an increased bone turnover at the site of a new bone formation. However, as with all bone scintigraphy, this is non-specific. The increased uptake can also be due to osteomyelitis, polytumors, or avascular necrosis. This is typical scintigraphic finding of a stress fracture. Delayed static image of the tibia and the frontal and oblique view show a characteristic evidence of stress fracture, depicted as a fusiform region of radionuclide uptake oriented along the long axis of the bone. Also, a case of stress fracture of tibia diagnosed by technetium bone scan. Although there were no abnormal findings on a plain X-ray of the tibia, the bone scan showed the uptake of technetium in the tibial diaphysis. So the localized focal uptake of the technetium suggests stress fracture. فنلاحظ إنه الإكس-راي normal while body scan show uptake. CT scan is less sensitive than scintigraphy or MRI in the early detection of stress injury, but it is more sensitive for the detection of cortical fracture lines. However, high-resolution CT is currently the most sensitive modality for detecting statistics changes in the cortex that characterize cortical resorption cavity. It is therefore useful in demonstrating stress fractures of the sacrum, pars interarticular, naviculum, and tibia. The findings on CT scan are similar to plain radiography, including sclerosis, new bone formation, periosteal reaction, and fracture lines in long bones. CT may be useful in differentiating stress fracture from a bone tumor or osteomyelitis if the plain radiographs are negative while bone scan are positive. This is CT scan of femoral midshaft show a bilateral intracortical area with reduced density and adjacent endocortical resorption site on the limb. This is area of decreased density in the cortex with endocortical resorption sites. Also, this is a gray cortex sign appear on CT scan representing a focal decreased cortical density surrounding a fracture site. This is the gray cortex appear on CT scan. احنا شفناها بالاكس راي وهذه بالسي تي. Also, this example of small irregular fracture line visible adjacent to the gray cortex. هذا irregular fracture. السيتي مثل ما ذكرنا إذا يمكن يعني يشوف لنا cortical resorption cavity. This is a sagittal CT scan of which show focal osteopenia in the cortex at the point of the fracture, indicate the development of cortical resorption cavity. هذا الكافيتي اللي هو بين decreased density, area of decreased density. Well, this is the STIR MRI image show the cystic cavity in the cortex. هذا cystic cavity اللي هو high signal with bone marrow edema. CT also is advantageous in certain situations over other imaging techniques. It is useful in differentiating healing from the progression. بنلاحظ هنا this is the frontal X-ray of the femoral neck show a region of sclerosis on compressive side of the femoral neck with focal variosteal reactive changes. كمان نعرف إن ده هو صار به healing or not. بس هنا بالCT coronal CT scan show the fracture line has nearly filled, فمعناها صار به healing. MRI is the most sensitive modality for detecting stress fracture and may also be useful for differentiating ligamentous or cartilaginous injury from a bony injury. MRI is able to detect abnormality weeks before a radiographic lesion. It has a comparable sensitivity and superior specificity with bone scintigraphy. Typical MRI appearance of stress fracture includes a periosteal or adjacent soft tissue edema, band-like bone marrow edema, T1 hypointense fracture line evident in high-grade injury. This is the case of 28-year-old female with a recent onset of pain over a region of the second metatarsal bone. At presentation, the radiograph was negative for the fracture of the second metatarsal, while MRI STIR image show a high signal intensity of bone marrow and a surrounding soft tissue edema. Indicate bone marrow edema as a result of stress fracture. نلاحظ هنا البون marrow edema with surrounding soft tissue edema, while X-ray the presentation was normal. Different stress responses on MRI in 3 different athletes. There is a in this picture, there is a periostitis along the medial cortex of the tibia manifest as a linear high signal intensity along the outer cortex. This is the periostitis high signal intensity. While in this picture show endosteal reaction with marrow edema along the endosteal surface of the femoral neck. In this picture, a patient with more severe stress response shows both periosteal and endosteal reaction. هذا periosteal and endosteal. MRI grading system for stress injuries. It is a useful tool in assessing the extent of clinical finding related to bone stress injury and predicting the time to return to full activity, the latter being especially important for athletes. STIR, T1 and T2 weighted images are used for characterization and grading. Grading is based on signs seen at MRI. Grade 1 is mild to moderate periosteal edema on the STIR, while no marrow changes. Grade 2, moderate to severe periosteal edema on the STIR, plus marrow changes seen on T2 image. Grade 3 include grade 2 plus marrow changes seen on T1. Grade 4, fracture line visible. فمن يطلع الفراكتشر line grade 4 mid pain changes بال T1 يكون grade 3. This is the case of a 22-year-old female professional athlete with a recent onset of forefoot pain, persistent after training. At the presentation, MRI show a high signal intensity on the STIR and low signal intensity on the T1. So it is a grade 3 stress fracture. This is a case of a 27-year-old soccer player suffered from midfoot pain with a recent increase in complaint. T1 image show a definitive fracture line in the navicular bone. Indicate طلع على fracture line معناها هو هذا grade 4 stress injury. This is the corresponding CT image axial and coronal show the fracture line and sclerosis. طبعا اكو هواي classification انا ذكرتهم بالمحاضره للاطلاع اللي يحب يطلع عليهم. Treatment and prognosis. Treatment is determined by the site of stress fracture and suitability for rehabilitation. The vast majority of stress fractures can be successfully treated non-operatively by avoidance of stressing activity. Most authors recommend operative treatment for cases of delayed union or failed non-operative treatment. Fractures at low-risk site are managed conservatively with analgesia, ice, reduced weight bearing, and modification of the activities until pain resolves. At high-risk site or inpatient where long-term rehabilitation is detrimental to their life, like athletes or laborer, orthopedic consultation is required. Risk factors like diet, vitamin D, and calcium should be addressed to prevent recurrence. Other factors such as gradual return to training and biochemical evaluation of gait, may be required. Bone density evaluation can be considered in this patient with recurrent stress fractures or family history of osteoporosis or stress fracture and explained by exercise activity. In addition to the risk stratification by location, ذكرنا أكو high risk و low risk site. Any displacement or proximal femur fractures with a fracture line more than 50%, the width of the femoral neck should also be considered high risk. Differential diagnosis of stress fracture include osteosarcoma and other body tumors can also present with periosteal reaction. Osteomyelitis has a marrow edema and soft tissue swelling. Soft tissue bruises has edema at the injury site but little marrow abnormality. Any question?